of Health, the province of British Columbia. Troy, if you'd like to explain to people what they're seeing on their screen.
Sure. So this first slide is a brief look at what GoToWebinar should look like on your screen. Depending on if you're joining with a PC or a Mac, it'll look slightly different. But the main features that you're going to be using today are the expand and collapse button, which is the orange arrow at the top. So if you look to the smaller control panel, you'll see a small orange arrow. And what that's going to do is it's going to open up that control panel. It's also going to close that control panel. And within this control panel, there are a few features which you can use, and the main one being the question box. So throughout the webinar today, you might have some questions, whether they be technical. If you're having difficulty using GoToWebinar, you can post them in there. Or if they're pertaining to the webinar at hand, you can also use the question box to voice those questions. And here's a closer view of what it might look like. And so the control panel with the orange slide out arrow, you can see is highlighted in red, and that's going to open and close your control panel. And the question box is where you're going to type your questions. So throughout the webinar today, feel free to use that question box. And at the very end of the webinar, those questions will be answered depending on how much time we have. I think we'll have a few minutes to field questions, and hopefully we can get through all of them. So we do like to hear from you, and please do use that question box. So I think now it's on to Humaira.
Hi there. At the end of this webinar, you will be able to describe why culture and diversity are important in healthcare, contrast elements of cultural sensitivity, cultural safety, and cultural sensibility. Describe the spirit of motivational interviewing, which is spirit of MI, and describe the link between the spirit of MI and cultural sensibility. So we have our welcome mat out. So thank you very much for this opportunity to work with you. And thank you for coming. We are looking forward to the webinar and learning together. My name is Humaira Mohsin, and I'm a psychologist and a researcher at University of British Columbia, and I work with CCMI as well.
And my name's April Lawrence, and I'm a master trainer here at CCMI. The Ministry of Health has 5 strategic areas of focus, and this webinar is part of the work towards an overall improvement in the quality and sustainability of the BC healthcare system. These quality improvements are both the experience of care and better health. The focus is to work across those involved in the healthcare in 5 areas. Improving access to primary care through a primary care home model, reducing demand on hospitals by improving care for seniors, reducing demand on hospitals by improving care for those with mental illness and substance use issues, improving access to surgical services and procedures, and improving the delivery of rural health services. Because the BC population is so diverse, addressing diversity has a part to play in addressing all of these priorities. The Ministry's patient-centered care framework describes 4 core components for patient-centered care that will be introduced over various parts of the presentation. These are dignity and respect, information sharing, participation, and collaboration. Although all of these principles are relevant when considering diversity, the principle of dignity and respect speaks to the need for active listening to patients and families and honoring their choices and decisions. This is done by incorporating the patient and family values, beliefs, and cultural norms into their care plan and care delivery, thus considering diversity as a particularly important element of fostering a respectful relationship. These 3 goals here are the better experience of care for professionals and people receiving services, better health at a sustainable cost, and improved population health. The Institute for Healthcare Improvement's triple aim has been adopted by patients as partners as well as many other healthcare jurisdictions. Working more comfortably across diversity obviously addresses this experience of care. The care that is positively experienced will be sought again, helping people stay healthy. It's also a more efficient system to run when those who have English as an additional language or who are traditionally marginalized can remain healthier through regular care. Feelings of not fitting in or not being accepted can keep people away from healthcare, decreasing their health and increasing their cost of their eventual treatment. As discussed in previous webinars, self-management support can be stepped up to meet people's needs. Today's webinar addresses diversity, which is on the first step. At its most basic, everyone who encounters the healthcare system deserves the information they want and need respectfully delivered in a language they can understand. The principles of working across diversity help ensure we can deliver this to everyone who comes to us. As was mentioned earlier, most people need this kind of support. The last 3 webinars are focused on engagement, informed decision-making, and health literacy. They go hand in hand with working well across diversity when providing support to patients. As we move on up on the steps of care, care becomes more specialized, and fewer people need those kinds of support.
So for a moment, think what would be different for health providers if they are working well across diversity. As you contemplate on this, we will share some of the ideas that we have heard from other practitioners who have taken the CCMI's diversity workshop about some of the things that would be different if it was easier to work across cultures. These were less nervousness about getting it wrong, more confidence about resources available to support patients and clients, better communication with more confidence in decisions about care, less stress, easier to have a patient-centered approach. So the question is that how would the patient benefit if the healthcare provider was working well across diversity? If I put myself in that position, I would trust the doctor or nurse more and would be motivated to discuss my health concerns and engage in my health management. All these would work in achieving the triple aim model that was mentioned earlier, making the experience and health of the patient better, along with low cost. So let's see how health disparities is affecting us in Canada. In a study in 2014 in Ontario, 20% of transgender patients reported avoiding the ED when they needed it. Suicide rates among the First Nation youth in Canada are 5 to 7 times higher than other youth. 37.5% of Canadian refugees report problems accessing health care due to language barriers. There are a host of things that could be different for patients and clients if we worked more easily across the differences between us. There could be a reduction in health disparities such as these. As we move on to the next slide, the research has also shown that people of the South Asian descent are 2 to 3 times more likely to experience a heart disease, kidney disease, stroke, and diabetes, and 10 years earlier as compared to other ethnic groups in Canada. So Fraser Health has therefore created the South Asian Health Institute to better understand the health needs of the South Asian population and also be a global leader in South Asian health. Now we move on to why is working well across diversity important? All these resonate with the triple aim to provide better care, make people more satisfied with the quality of care, and ultimately bring the cost of health care down. The first one, it reduces disparity in health services and increases detection of culture-specific diseases. An example of culturally specific diseases of anorexia. It is more prevalent in individualistic and well-developed countries where issues of body image are glamorized and thinness is promoted as an ideal form. It addresses inequitable access to primary health care. People living in remote areas often have less access to health care. Then it impacts health status of culturally diverse communities. There are numerous examples. Here are a few. Health Link BC, provided by the Ministry of Health, is a resource available to British Columbians which provides detailed information about health care topics and where to find health services in BC, such as hospitals and clinics, as well as non-profit organizations that offer services and the locations where they are offered. The 811 option allows people to speak with a health services navigator in more than 130 languages. Another example is the University of Victoria's self-management program, which provides peer-led 6-week programs throughout BC to help people and their families learn how to live better with chronic conditions. Some of the peer leaders and sessions are for First Nation groups or in Punjabi and Chinese languages. The University of BC Intercultural Online Health Network, ICON, funded by the Patients as Partners, provides culturally relevant, linguistically appropriate, trusted health information on chronic disease and self-management education for multicultural population, including Punjabi, and Chinese language-speaking forums with in-person attendance of up to 1,500 people, with live webcasts available throughout BC. A chronic disease multi-language website, online materials, social media, and Aboriginal learning circles, and other multicultural language materials and public educational sessions. ICON works in partnership with numerous community organizations, and in the forums, audience members are provided information by healthcare professionals and are able to ask questions in their first language. As well, UBC is able to attract volunteers from the university's Faculty of Medicine department. The medical students get involved as volunteers, thus reducing cost for providing the forum, and then also learn about multiculturalism as it relates to medicine that they will use in their practices. ICON has also been able to include content in the medical students' curriculum. Another good example is of Fraser Health project, which I mentioned earlier. Fraser Health has created the South Asian Health Institute to better understand the health needs of the South Asian population and be a global leader in the South Asian health. The goal of this institute is to support Fraser Health programs and services to improve the health and health outcomes of the South Asian population in a culturally appropriate way through innovative, evidence-based care and research, and local, national, and international partnerships. Through partnerships and prevention education, Fraser Health aims to empower the South Asian population to make healthier decisions that will improve their health and result in people living longer lives. Its main focus is at 4 levels. The first one is at program level, which focuses on South Asian health centers for diabetes, maternal health, mental health and substance use, youth and health promotion. The second focuses on research, that is to develop capacity, act as a network for other researchers, distribute knowledge to community. Another one is the local and global links, that is to network and collaborate with global partners through Canada-India Network Society, SINS, to create community engagement. Lastly, it aims to facilitate partnerships. South Asian Heart Risk Initiative and Health Promotion is a partnership between high schools, and Fraser Health Cardiac Program is a good example. Another good example is of Progressive Intercultural Community Services Adult Day Program Initiative. It's a daily structured program with activities, health-related services, and rehabilitative services. The initiative's goal is to provide respite for family caregivers of seniors. Another example of initiatives that addresses culturally diverse communities is of the First Nations Health Authority. As of October 1st, 2013, the First Nations Health Authority has taken over and will plan, design, manage, deliver, and fund the delivery of First Nations health programs across British Columbia. First Nations Health Authority's vision is to transform the health and well-being of BC's First Nations and Aboriginal people by dramatically changing health care for the better. BC First Nations, the province of BC, and the Government of Canada have all determined that First Nations health disparity are no longer acceptable. A new relationship between these tripartite partners was forged, and a series of precedent-setting agreements led to the creation of an First Nation Health Authority. And lastly, another reason for why working well across diversity for us is important is it responds to the British Columbia's changing demographics and an increasing diverse population. Canadian community has always been enriched with the process of immigration that makes the community needs diverse. All right.
So considering that working well across diversity is so important to supporting the Triple Aim and the STEP care model, let's define a few terms. If we define culture, cultural sensitivity, cultural safety, and cultural sensibility together, then we can be sure that we're talking about the same thing when we use those words. So what is culture? We propose the following as useful definitions of culture. Whatever it is that one has to know or believe in order to operate in a manner acceptable to a group's members, or defined by the person in relationships to groups they identify with based on heritage, individual circumstance, and personal choice. These definitions of culture may surprise you in some ways. In the West, in the dominant Canadian culture, and in most institutional cultures, culture is thought of as being explicitly attached to an ethnicity or culture of origin, and is something that's often made visible by physical features or perhaps through an accent in speech. These definitions are more comprehensive than that. The second comes from the American Association of Medical Colleges, or the AAMC. Using these definitions, you may see yourself operating across several cultures already. Your golf foursome likely has a culture. The knitting group you belong to, as opposed to all the ones you haven't chosen to belong to, has a culture. Your friends, your family, and your workplace all have cultures. You can layer your ethnic understanding of yourself onto all of these as well. The AAMC goes on to say that cultural identity may be affected by such factors as race, ethnicity, age, language, country of origin, acculturation, sexual orientation, gender, socioeconomic status, religious or spiritual beliefs, physical abilities, occupation, and many other factors. These factors may impact behaviors such as communication style, your diet preferences, health beliefs, family roles, lifestyles, rituals, and decision-making processes. All of these beliefs and practices in turn can influence how patients and healthcare providers perceive health and illness and how they interact with one another. So cultural sensitivity is knowing what the differences as well as the similarities exist without assigning values, for example, better or worse, right or wrong, to those values. Cultural sensitivity is one way to position ourselves in response to knowing that there are many cultures and many ways to understand the world around us. Knowing that there are differences, we can essentially do one of two things. We can decide that there are many ways to be, but only our way is right, or we can know there are many legitimate ways to be in the world. We don't need to agree with every element of another culture to have respectful conversations, even across our differences. And cultural safety. Cultural safety is an outcome of interactions where individuals experience their cultural identity and way of being as having been respected or, at least, not challenged or harmed. Cultural safety is the outcome of dealing with a healthcare provider, or anyone, that's been culturally sensitive. If people feel disrespected, they are unlikely to seek out a similar interaction. When a young Aboriginal woman comes to you, concerned because her grandmother has told her that eating strawberries will cause her unborn child to have terrible birthmarks, how you respond to her will affect her feelings of cultural safety and, consequently, her desire to return for more care. Cultural safety is the goal of all of our interactions with patients and clients. When you put all this together, we get cultural sensibility, an openness to emotional impressions, susceptibility, and sensitiveness related to another person's moral, emotional, or aesthetic ideas or standards. This may sound academic or abstract, but really it's simply putting cultural sensitivity into practice. It's remaining open to the different ways that other people can approach or understand the world around them. It can have a real practical effect on healthcare when it is applied. Let's look at how working from a place of cultural sensibility is different from the dominant way of approaching culture, and then we'll consider the implications that each understanding may have. When we respond to culturally sensitive issues, the how we do so is even more important. Respect can be perceived in our tone of voice.
So now we're going to talk about a contrast between the cultural expertise with the perspective of cultural sensibility. You may recognize cultural expertise as the way that institutions often discuss culture. So, for example, when thinking about culture, someone holding a position of cultural expertise sees culture is an externally recognized characteristic, static, one-dimensional, race, ethnicity emphasized, unitary. In contrast, culturally sensibility focuses on culture is an internally constructed sense of self, dynamic and fluid, multidimensional. Race is one aspect, diverse, differentiated. So then, when thinking about culture, someone holding a position of cultural expertise sees culture as acquiring knowledge. In contrast, a person who wishes to be culturally sensible acquires principles. Similarly, for cultural expertise, there are experts about understanding cultural perspectives of certain groups. In contrast, from a culturally sensible perspective, no one has ownership of expertise with respect to identification of cultural belonging. To have a more meaningful understanding of cultural sensibility and even expertise, let's look at the example on the next slide.
So cultural sensibility means that it is impossible and unwise to tell a single story about someone. For example, you are a first-generation immigrant with Indian parents. These single stories can be true, but many other things are also true. People may have all, or some, or none of the characteristics we stereotypically associate with the facts about them that we can see. Seeing people as just one thing may feel convenient, but it is rarely helpful. Here's a Canadian family. The woman here is 30 years old. She was brought to Canada by her Romanian parents when she was a small child. She's church-going and she's faithful, active in their cultural community, and has enrolled her son in the Romanian folk dancing club, which she participated in as a child. Her family came to Canada very reluctantly, and her parents never felt truly at home here. They never developed strong English skills. Here's another Canadian family. This woman is also 30 years old and was brought to Canada by Romanian parents as a small child. Her family was thrilled to come to Canada. They saw it as an adventure and an opportunity. They've remained active in the Romanian cultural community because it's important to know where you come from. But this woman was encouraged to embrace the new country. Her father spoke very poor English with great pride and enthusiasm. This is an example of how culture or ethnicity may be far less important than something we call acculturation. Imagine how each of these women would feel about being Romanian and about being Canadian. Any assumptions we might make based on a tick box understanding of their cultural attributes are likely to be wrong. Imagine then that one of these women, either one of them, then goes on to become a doctor or a nurse or an engineer or a teacher or another profession with a strong cultural identity of its own. How could that further add to her acculturation and limit our ability to make cultural assumptions about her? How might healthcare providers have some possible misunderstandings when these families access healthcare services? With a very diverse communities existing across British Columbia, and there are subcultures among every minority, our task as healthcare providers becomes a little more challenging. But we can work towards working well across diversity to provide patient-centered care, and it becomes more of a cultural sensitivity, which would help us make sure the triple aim and the step care models are a success. What do? You can talk to people. You can ask people what they think. You can treat every person in front of you as if you can't assume things about them. You can treat their responses as legitimate understandings of the world around you, to which you might be able to add a bit more information, or you might be doing something else that seems right for you in the moment. At first, you might think this is all more complicated than just learning the 10 dominant cultural characteristics of the group you serve. It may feel disappointing or even frustrating. But while there are cultural generalities you can make, and we'll talk about them later, it's actually easier to deal with this messy understanding of culture. This approach is based on principles that can be applied to all people rather than needing to learn specific knowledge for each group. So there are a few things that would help you to be culturally sensible. There are more general rules than specific questions. Cultural sensitivity is fluid and not fixed, as mentioned earlier, when it was compared with cultural expertise.
So cultural safety is not built on knowledge and understanding of a culture, nor even sensitivity to it. The skill does not lie in knowing the customs or even the health-related beliefs of ethno-specific groups. The step before that lies in trust. To achieve that, there have been a number of initiatives and programs. Better patient engagement leads to better health. In BC, the province is expanding home health monitoring through a partnership with TELUS. This technology allows thousands of patients to proactively monitor their chronic conditions at home and learn how to better manage their chronic conditions. Through technology, patients get the care they need without traveling to see their care provider. This service also is a support to family caregivers and improves coordination of services between health professionals and working in the community. The way it works is that patients are provided with a mobile tablet and a software which enables them to connect with a care provider from their own home. Patients are given support and training how to record their blood pressure, weight, and oxygen level from home. In this way, patients are aware of changes in their health very quickly. Daily responses are sent to a home health monitoring nurse who monitors results and maintains regular contact with the patients and their physician. If there are any issues, these are quickly addressed. In the pilot phase, home health monitoring was offered to heart failure patients in a select area in BC. 97% of patients would recommend the service to other patients. Patients also said that the home health monitoring improved their self-management and resulted in better health, as well decreased their emergency room visits. Based on the success of the program for patients, families, and care providers, the program will be expanded to patients with chronic obstructive pulmonary disease in Island Health. Vancouver Coastal Health will also expand Check for Home, a home health monitoring solution designed specifically for patients' transition from hospital to home, bridging the gap between hospital and community care. Another example of patient-centered service is of British Columbia Patient-Centered Care Framework. Its vision is that BC will pursue patient-centered care with a vision for achieving a healthcare system in which the patient's voice is anchored in all behaviors and drives all activities of the health system. A culture of patient-centeredness is self-evident across the health system and is integrated into existing healthcare programs. Healthcare programming is built upon the patient-centered care principles throughout planning, implementation, and evaluation. A very useful model that has been of great success in engaging people is in their health management, whether it is chronic disease, mental health problems, or lifestyle issues, is the CCMI process of seeing things through motivational interview. CCMI sees spirit of motivational interview, or the spirit of MI, as the foundation for each interaction can help us to be kind, helpful, and culturally appropriate, as well as allowing us to be more comfortable if there are aspects of a patient or client's choices that we don't agree with. If you were on the webinar about engagement, Dr. Kathy Reams introduced you to the spirit of MI. The spirit of motivational interview is a philosophy or general approach to working with others. Motivational interview is a collaborative conversational style to strengthen a person's own commitment to change. Since the result of giving information is so that people can make changes, self-manage, it makes sense to adopt a philosophy that can support change. The spirit of motivational interview is described by Miller and Rodnick, the founder and researchers who established this approach. There are 4 things that make up the spirit of MI: the compassion, acceptance, partnership, and vocation. It has been seen in studies that when clinicians demonstrate the spirit of MI in their interactions, the people they are working with are more likely to change. This was done in a number of studies by Milner and colleagues. You can see this is an acronym, right? CAPE, a memory device. Now let's look at each of these elements a little more closely. The first part of the spirit of MI is compassion. Compassion is caring about what is good for another person and letting it become important to you too. The interaction is done with heart. This is very different than convincing someone of what you think is important for them. Receiving compassionate care is linked to greater satisfaction with care. Being compassionate includes being kind, empathetic, and mindful of differences. The second aspect of spirit of MI, acceptance, means you respect the other person and their right to change or not. It does not mean you have to agree with the person's behavior or beliefs. People who are competent have the right to make choices. Sometimes we may find these choices puzzling, but it is not our place to decide what is right for another person. We can help people make choices that better fit their goals, not our goals, and their understanding of what is appropriate for them. Sometimes, as clinicians, we do work with people whose competence to make decisions is compromised. We aren't talking about that situation here, but respecting their autonomy as much as possible is still important. Partnership is working together with another person and recognizing them as an equal. Avoid the expert role as clinician, recognizing people have expertise about themselves. MI is not done to or on someone, but is done with a person. Our patient as partners document says it is not doing to, for, but with, since doing for doesn't mean that patients were working in collaboration. Evocation means bringing out another's strength and knowledge about the situation and themselves. People already have within them much of what is needed, and our task is to evoke or call it forth. The ideas come from the person, and our job is to help draw them out. Adults mostly don't like being told what to do in their personal lives. Most people's initial reaction to being told what to do is to put up resistance.
So far, we've established that no one has a single story. We've talked about the definitions, and one is cultural safety, which is the goal of all of our interactions with patients and clients. We want people to feel safe in our care. Then we reviewed the spirit of MI, which is compassion, acceptance, partnership, and evocation. And now we need to put it together in how we interact with others. To communicate effectively across all kinds of cultural diversity, there are some questions you can ask and ways you can speak with your patients and families that will be helpful. You can ask them how they explain their illness. This might have a great deal to do with how they perceive possible treatments. You can think here of all the ways that people explain the common cold. They get a cold when they fly. They get one when they're stressed. They get one when their children go back to school. They get one when they get caught in the rain. People may have deeply cultural explanations for illnesses. Remember, you don't have to agree, just respectfully understand. The spirit of MI would advocate being compassionate. You can ask people about other advice they have sought out or that they're getting. People often get contradictory advice from different people in their lives. Knowing more about what they know or believe could help you to be more effective. Following the CAPE model based in the spirit of MI, you can accept the differences in people's preference for the care or the treatments they explore. You can ask, with respect and openness, which are those treatments they're trying? Many people take alternative medications or seek alternative treatments along with Western medicine. They also regularly lie to their providers about it as they assume they will be judged. Open discussion gathers more information for you and builds their trust. This is the partnership element of MI and informed decision-making, which is on the first level of the stepped care model we discussed at the beginning. You can negotiate different options. You can use and instead of or. Having a cultural sensibility does not require you to suspend your expertise or pretend like you don't have information that's useful. Patients and clients benefit greatly from the knowledge you have, but it's how that information and advice is offered that promotes or destroys cultural safety. Other webinars in this series will offer concrete techniques for this. Look out for ones such as Ask, Tell, Ask in one of the webinars in the following weeks. It's also quite frequently used in brief action planning, which will be presented on the 21st of this month. You can reflect what you hear back to them. Reflections are a specific communication technique that you can learn more about in CCMI's MI training or in our half-day workshop on diversity. A reflection is when a listener reflects back the words used by the speaker or guesses at what might be coming next to show they understand or to correct misunderstanding or to advance the conversation. Finally, you can explicitly offer to work in collaboration. People will continue to do the things that they feel are necessary for their health and well-being. You can either engage and understand what's being done, or you can choose to remain in the dark. But when does the ethnic or population makeup of those you are working with actually matter? Sometimes it might be quite important when you serve people who are mostly struggling with housing stability, or who are mostly refugees, or transsexual men, or South Asian seniors. Here are some times when the cultural identity of your patients, clients, and their families may matter. When you're planning a support service, such as culturally appropriate supports or translation. You may be planning to have an additional service explicitly related to ethnicity, such as Tagalog translation or an Aboriginal patient navigator. You may be hiring a peer worker or providing another service. In this case, it's critical that there be a match to the dominant or targeted group. but you know from a position of cultural sensitivity that you cannot assume that everyone with brown eyes or from a particular community will need or want the service you're providing. It can matter when you're deciding on referrals to additional services. Some of these services may have a target group. You might refer your patients or clients to another support service. In this case, it would certainly matter to make sure that they fit the target group or not. Or there might be another way as you think of your service. You may see another way in which your working environment means that a specific group of people that people can be placed in, providing culturally relevant reviews of documents or telling you ways that you can present messaging that would better relate to their community. There might be lots of ways where you can engage with people where the population that they're in matters. But again, a position of cultural sensibility would require you know that not everybody fits there. So we've talked about the dangers of seeing people as just one thing, the danger of telling just that single story about them, and forgetting acculturation. We've talked about cultural safety as the goal of our interactions, as this is a significant factor in trust and whether or not that patient or client will return for you for further care. We've talked about using the spirit of MI as a foundation for those conversations and how it can help you work openly with someone whose choices you may not completely agree with. Lastly, we talked about when the group identity of a person actually matters for their care or for your service. The ultimate goal is to provide a sense of safety for your patients.
So this diagram shows the process of how we can achieve cultural safety, though we need to be mindful that the sequence is not necessarily hierarchical, and any change in any of the components can and usually impacts the others. This brings our webinar knowledge sharing to an end. So I'll open up the floor for any questions, and we welcome you now to share any questions or comments about diversity and cultural sensitivity, competence in the comment box, and we'll sort of respond from there. You can type them in the box that Troy mentioned at the very beginning. I haven't seen any questions as yet, but if you have any any experiences or anything that has helped you to work out diversity issues in your work, at your workplaces, with your clients and patients, that's welcome too. How you work out, or if you've had any challenges and how you manage that, or you're still wondering about those challenges.
We have one question from the audience. It's more of a technical question, and it's about the access to the recorded webinars. And so after this webinar today, you'll receive a follow-up email with directions on how to access the materials that are available to you. You'll have to sign into CCMI's website to get into the secure site, but from there you'll be able to watch the webinars and also download any of the documents that have been available in the past.
Yeah. I was just thinking about how diverse our community is, and in my personal experience, sometimes I too see a person whose cultural background I'm not very much aware of. So with all these things, I start with giving them that option, or perhaps that idea, that I would be open to any new ideas, and I respect the individual culture they come from. And if I am sort of overstepping anything, they can always tell me. I would respect that. And that makes the process more easy for communication and developing that trust. So that works for me. Is there any other comment that anybody wants to share? Seems there are none at the moment.
Well, then, out of deference to the people that remain on the line, why don't we move forward to the end and give you the last bit of information that you need? And please know that at any time until we actually turn this off, you can pop a question in the chat box. And chances are very good if you have a question, someone else has exactly the same question too, and we'll probably appreciate your sharing it. So I'll just make sure that we give you all the information that you're to.
April, I think we lost your audio.
You didn't lose my audio. I put myself on mute and forgot to take myself off. My apologies, everyone. I was just suggesting that maybe out of deference to the folks who are still on the line, we should make sure they have all the information we can share with them before the end of the webinar. And if anyone would like to put a question in the chat box, then you're welcome to do so as we wrap up, that we never run out of time till this is over. So we'd like to encourage you to learn more about diversity. The skills discussed in this webinar are much like any other skill. They require practice. We encourage you to learn more about them by contacting your Patients as Partners lead in your health authority or in the ministry, or you can contact CCMI directly. There are other agencies funded by the Ministry of Health that work to support diverse communities. We've talked about some of them over the course of this presentation. One of these is the UBC Intercultural Online Health Network, or ICON, at iconproject.org. And the other is the University of Victoria's self-management programs at selfmanagementbc.ca. Both of these Patients as Partners funded organizations work to optimize chronic disease prevention and management for multicultural communities, patients, and healthcarers across British Columbia. Also, the ministry's HealthLink BC provides information in over 130 languages and can be reached at healthlinkbc.ca or by dialing 811. Is that a question that I see, Troy?
Yes, it is. That came from the audience just as you were speaking.
Ah, fair enough.
I'll just read it out. It says, work in home health. We struggle to deliver services for those of some cultural beliefs. Our program assumes a high value on self-reliance. Some members of our community are more inclined to rely on help. Yeah, I totally agree with that. Certain communities are more collectivistic and they focus more on help from their family members. And again, they see the caregiver provider as an expert. So they prefer to be sort of told what to do. And sometimes it's difficult to evoke ideas from their end because they have this idea that the healthcare provider is an expert. And that becomes a challenge at times, I agree. April, would you like to comment on that? Anything else?
Well, again, the spirit of MI would very much ask you to sort of meet people where they're at. And techniques like ask, tell, ask, and the conversational techniques taught in with the spirit of MI can help sort of uncover how willing people are to engage. And the self-efficacy principle of self-management would suggest that if they're willing to do small things, then maybe small things can lead to big things. And honestly, we do just have to meet people ultimately where they're at instead of sort of punishing them for how they sort of see the world, which might be very different than how we see it. And I know it can be a source of frustration when your program sort of requires you to help someone be independent and you might perceive them as not wanting to. It can be a huge tension for you in your practice. So what the spirit of MI might be able to do is not necessarily convince the person that they should take on self-responsibility, but but might actually just sort of allow you to find another place to stand where you can appreciate their choices and not feel it as a failure of your own practice or work. That acceptance can do a lot to liberate you as well.
I also feel that the spirit of MI creates that atmosphere where the person trusts and feels comfortable in the presence of the healthcare provider. And the brief action planning technique is so useful in starting from the point or level where the person is. And it might be very small from our perspective, but it's huge for them. And accepting that at that level and sort of scaffolding them ahead slowly and gradually is quite the technique is quite effective, and it works well with people from very diverse backgrounds, in my experience. Yeah. So using different techniques, being mindful about and being sort of open to differences is, I think, the basic philosophy or perspective that helps you to work with diverse communities.
I see there's another comment saying that they're not always eligible for programs. And perhaps that's attached to the comment that people who prefer to be more passive might not be qualified for programs that require them to be more active. Again, I would strongly encourage you to watch for the technique Ask, Tell, Ask, which is an MI spirit-based method for making sure people understand the information that you have to give and the impact of their choices. So being able to make sure that they at least understand that their exclusion and what they could do to shift that, then at the very least that allows you to share information that might be important for them to have if they're interested in receiving it, and still stay in the spirit of MI. And sometimes people don't fully understand that that the consequences are the program qualifications based on what they're willing to do or not do. And if they know that, that may or may not shift their perception, but at least as a practitioner, you can make sure you gave them the information that they needed.
Right.
Well, I haven't seen any other comments come in. Troy, have you? Because you're the first receiver.
Nope, nothing yet.
Okay, well then, why don't we move towards the end of the webinars? We're also sort of running out of time in people's lunch hours. So the next opportunity to engage with us in a webinar is on September 21st, when brief action planning will be presented. It's been mentioned a couple of times here today as a way to help build people's self-efficacy for self-management, and also to support people who have a little more self-efficacy to manage their conditions in more significant ways. And I'll be joining you again on September 21st, and I will be joined by Bruce Hobson, a physician in the Lower Mainland, to talk about using brief action planning and just what it is. And so you will receive a survey since you have participated in this webinar, and please, we hope that you participate in filling it out in order to help us understand what we're doing well and what we could improve here at CCMI and with this webinar series. So I'd love to thank you all for taking the time to be here and to join us today, and for the questions and comments that did come in. And hopefully we will see all of you again next week.
Sure. Thank you so very much from my end too.
Thanks all for joining. Bye now.
Bye-bye.